5 o'clock, and we'll begin the meeting of the Board of Commissioners of Public Hospital District Number 1. It is with pleasure that I welcome everyone in the room, and thank you very much for attending. First item on the agenda is approval of the agenda, and if there are any items to be put on the consent agenda, could you raise that now? Moved and seconded, all in favor? Aye. Motion passes. The consent agenda is up now. Includes the minutes of the board meetings of September 22nd and the special board meeting of October 24th. Approval of checks and warrants, the foundation report, and the finance committee meetings from last month's meeting. So I hear a motion to approve the consent agenda.
So moved.
Thank you. Rob? Rob and Rob, thank you, and thank you. It's been seconded, all in favor? Aye. Motion passes unanimously. Quality.
If I can take this moment, we took 3 months to look with Randy at the data that we got of Project Access, and we thought that worked well to just kind of build on information from meeting to meeting. So I have asked Mandy to kind of do the same thing around quality. And we're going to start with really kind of history of how healthcare and hospitals, where we've been in quality. So part 1 is kind of how this journey began and where we're at.
Yeah. So in case you haven't met me, I think I've met Bob even, but just to remind you who I am, I'm Mandy Wilson. I'm the Director of Quality and Risk Management, and I've been at KVH for 8 years. I started out here as an RN on Med-Surg, and then took a little journey as one of our first lean facilitators, and I've been in my current role for 4 years. So it's really important work to me, but I wanted to make sure it was shared with you too, that that's one of the key things that the board is responsible for, is the quality and safety of the care too. So for the 3-part series, like she said, is the history of the patient safety movement. That's what we're going to focus on tonight. So don't get overwhelmed. We will talk about what we do with all of this information next time. And then the last piece we'll talk about is specific board responsibilities for quality and safety. So tonight I'm going to just start out with a story, like I like to, and then talk about internationally and what's happened here at KVH over the last few years. So this is me and my cohort of nurses from UW, and when we graduated from school, we thought we were going to change the world, right? You know, you're going to save people's lives. And within a few months of my job at Harborview, I committed a medication error, and it was horrible. I still remember it to this day. I had this cute little 80-year-old stroke patient, and she was doing so well. And the horror that I had given her twice the dose of her blood pressure medication. The fear in telling the physician and my preceptor and the patient and her family about it, and that she would be harmed. It was really an awful experience, having the shame and having to report it, and all the anxiety that came after that about would I be disciplined or fired. It was a really terrible experience. But fortunately, the patient wasn't harmed. She just needed additional monitoring, but I thought I was alone. I thought I was the only person that this has happened to. Unfortunately, that's just not true, and I didn't know it at the time. Unfortunately, Harborview was very supportive in it and didn't fire me, but as recently as 2014, the World Health Organization estimated that in developed countries, as many as 1 in 10 patients is harmed while receiving hospital care. And this might not be news to all of you, board members and being around healthcare, but it certainly was news to me in 2006. So, kind of the history of patient safety, it's a term that gets thrown around a lot. I mean, we know from the beginning of healing, disciplined healing, that the Greeks said, primum non nocere. So, first do no harm. And that's what most healthcare providers think of as part of their first charge, is to do no harm. But if we were saying that centuries ago, we knew there was obviously a risk of harm in providing healthcare to people. Unfortunately, that measuring that or thinking about how to prevent it wasn't prioritized, and there wasn't a way to track that information for centuries. And it really didn't start till late in the 20th century. So the first place that we saw it in the United States, and really internationally, was in the 1980s. In the United States, we had a media program on 2020 called The Deep Sleep, 6,000 Will Die or Suffer Brain Damage. And in the opening of this newscast, they said, general anesthesia is safe most of the time, but there are dangers from human error, carelessness, and a critical shortage of anesthesiologists. This year, 6,000 will die or suffer brain damage. This ended up being a pivotal moment for patient safety in the United States. Key anesthesia leadership had just started as part of the ASA, and they've been looking at researchers from Aviation Accident Review, and they developed the first International Symposium on Preventable Anesthesia Mortality and Morbidity in 1984. And this organization really started the first patient safety organization, and that was anesthesia led the way in that. And that started in 1985. And they were really the first people to use the phrase patient safety as well, which is kind of interesting, but they're pretty proud of it too. And so what most people remember though is in 1999, but this is more than 10 years later, the Institute of Medicine released their report that said healthcare in the United States is not as safe as it should be and can be. At least 44,000 people and perhaps as many as 98,000 people die in hospitals each year as a result of medical errors that could have been prevented, according to estimates from 2 major studies. Even using the lower estimate, preventable medical errors in hospitals exceed attributable deaths to such feared threats as motor vehicle wrecks, breast cancer, and AIDS. And this is what most people consider as the impetus for the patient safety journey in the United States. So quite a few things came from this. President Clinton established the Quality Interagency Coordination Task Force. And one of the key things here is it said to adopt human factors training such as crew resource management. And that was a formal teamwork training that came from aviation industry. It made national news, but one of the things that was overlooked by the public, but is very clear in quality and patient safety, is that the majority of medical errors aren't the result of recklessness. They're the individual intent doing harm. It's systems failures, processes, and conditions that lead individuals to make mistakes, or at least fail to prevent mistakes. We're not talking about people, bad eggs, that are going out there trying to harm people. It's really the systems we're putting them in. And this makes sense when you think about, we're dealing with human beings, and we treat them like they can remember everything, and if they're just vigilant and work hard, they'll remember. But we really can only remember 5 to 7 tasks at a time. We just had a great presentation today about multitasking. We don't do it. Task switching, we make errors. We're human beings. And this is just a slide that talks about that, about the hierarchy of controls. Usually people jump to administrative controls. You can see that right there in the middle, but they depend on employee behavior and they're less reliable. Instead of looking at eliminating threats to patients with system redesign. And so this is pretty detailed, but some of the things we look at when we look at improving processes and the systems we work with, instead of looking at asking the individuals to just try harder. So because of this, the IOM also suggested that we not look at punishing people when they make mistakes, that would not make the system better, and it wouldn't prevent other people from making the same errors. So this is really the starting point of just culture, too. So the definition of just culture is where people feel safe to bring up problems, right? I know that if I tell you about my error, like what I experienced at Harborview, I'm not going to be punished because I made a mistake, because it's simple for me to make a mistake. You know, the system allowed me to easily harm a patient. But that organizations, they have to say, we're going to make problems visible, we're going to work on them, and it's something we all value, right? It's important to all of us to work on this. So, but it shouldn't be blame-free, right? We want to go away from blame and shame, because it doesn't actually prevent future occurrences or improve the system. But we also don't want to say, if someone is being intentionally reckless or taking risks, that we're going to, absolve them from any responsibility. So we need to make sure that is, there's accountability for that as well. So what happened is in 2005, so again, 6 years later, there's actual language that says all organizations should have a patient safety improvement project and work as transparently as possible. And they created law that protects people to do this quality improvement work and patient safety work, right? If I'm gonna get sued because I participated in this and what I contributed, people wouldn't participate. So Washington State has these RCWs that also protect us in engaging in quality improvement and patient safety work. This is just a timeline to show this visually, but there's been lots of work that's been done. You can see even in some of the team steps, they consider the patient safety movement really starting in 1995, but you know, it's been fairly recent that we've said that this is important for all healthcare organizations to be a part of. So what have we done at QBH? Well, one of the reasons we have quality improvement and safety is because it's the law. We have to participate in, have a program that comes to you through QI Council and here to the board. But it's also the right thing to do. So one of the things we've done, the history of some of the quality directors from what I've heard, the stories I've heard, you know, it really started back with leadership from the board with Joan Glover and Sharon Johnson and Dr. Johnson that said, we're going to do some studies on this. We're going to start looking at what our issues are. And so back in 2006, which actually I think was when Rhonda started in the quality position, we were looking at the hospital survey on patient safety culture to see how we were doing. And you can see where we really needed to work on was right here, this feedback, communication about error, non-punitive response to error, right? So making people feel safe to report, and hospital handoffs and transitions. And the yellow, let's see, the black kind of line is the most recent, and we've definitely improved in a lot of those areas, but again, the last was in 2014. But previously we did all hospital too. We looked at a larger group of people and said, gosh, what do we need to work on and where can we go? So I started in this role back in 2012, and I know there was a lot of work done before this that, like I said, Sharon Johnson and Rhonda did, but we prioritized just culture, and we said if we're really going to make just culture possible, the leaders, the ones who address the incident reports, they need to be the ones first and foremost that understand just culture. If they're responding in a punitive way to mistakes, it's going to perpetuate the shame and blame culture. So that's where we started, and all our leaders were trained in that. And this, I just wanted to point this out, I think this was 2013. They strongly encourage AHRQ, these 10 things. Well, KBH was already doing all of these things in 20. This was not new to us to be working on any of these. So just kind of where we've been as far as the journey, we were kind of in the forefront of patient safety, especially for a critical access hospital. Then in 2013, we said we have to look at that reporting system, right? If people can't report easily, so that's where you see these safe boards and our electronic incident reporting system. So making it easy to report, making it safe, making it visible. The safe catch that has come here, that was all part of that, right? Recognizing and making people feel okay about reporting possible near misses. In 2014, we said we're increasing our occurrence reporting, and so our non-punitive response to error has increased, you know, it's been better. Frequency of reporting events has definitely gone up, but these handoffs and transitions of care are still really rough for us. And so that's when we started Team Steps, which is a, that goes all the way back to the Department of Defense, started this based on the aviation industry. And it's team strategies and tools to enhance performance and patient safety, really centered around communication and teamwork. In the last 2 years, we've trained over 500 staff in this, including some of you, I think, have gone through the training, which is really wonderful. So that's right there. Yeah, you went there. Yeah, and it's all of our senior leaders. But other communication and awareness activities that were done, you may have seen when you've gone out with us, is our huddles. It's all about communication and proactively thinking about what's happening and that teamwork. Tiered data, right? We've done a much better job about being transparent with data and linking it throughout the organization. Debriefing, which is a tool we use to immediately after something, what can we learn from it? And Gemba, going to where the work happens and looking at the work. So these are just some of the things that KVH has done, really to increase our reporting, right, and the safetyness of reporting. Next time I want to talk about, okay, what do we do with all that, right? So we learned a lot about our opportunities for errors and problems, and so that's why next time we'll be looking at our process improvement, which is just the citations, and the quality improvement activities that we do. So more specifically around the philosophy of those tools and resources and how we do that here.
The patient story was your experience at Harborview?
Yes. Yes. So
Thank you, that
it was
was
a demo. I
very
remember it. I remember it.
very moving to hear that though, what are your thoughts?
Well, and I would just point out, like tomorrow, Dawn is gonna be in Seattle at what's called the Physician Safe Table. And it's physicians from all over, the state of Washington come together and talk about patient safety, and they do it under the umbrella of those RCWs, so they can share openly about how, things that have happened and how they improved it or make sure it doesn't happen.
It's the dashboard right now. Anything on the dashboard?
So where are you gonna be, are you talking about the
The
QR
QI council dashboard, yeah.
So those are pages 11 and 12. The QI council meets on next Thursday at 4 o'clock. Any comments on the dashboard? All seem to be sorted up and down.
And we have so few occurrences too that I think it's gonna look like that. I mean, it's one of those ones that,
We've seen a pretty steady, more or less increase in readmissions.
I have someone working,
Okay.
I'm really excited about, but I have a person that works on that. Lindsay Haney in my office is a quality improvement coordinator, and she's partnering with the A-team, and we're looking at some tools and resources that we use to take a look at that. We're currently, with the Medicare readmission rates, no different than, the average in our state and nationally, but yeah, this is a slightly different metric. It is our own. We look at both observation and inpatients and not just Medicare patients. So we can't really compare it to those numbers, but it's definitely something we don't like doing.
And I assume you would try to speculate.
That's why they're looking at it, so we've got plenty of cases to look at and see what we can do.
Whether or not it's helpful, and I don't mean this in any apologetic sense at all, but when you look at data like we have it displayed here, this is called run chart data, where you follow things that are going on. It's also important to realize that there's inherent fluctuations that are just random. So as a way of trying to decide what's statistically significant, or oftentimes people use kind of if it's less likely than 5 times out of 100 to be occurring, maybe it's something you should really pay attention to as important. In order for a run chart to become statistically significant, or be likely attributable to something other than just random fluctuation, you really need 8 consecutive points above the median. So if you drew a line down the middle of those readmission rates, you would say probably we've got 2 in a row that are above the median of 8. So I'm not sure that we're not looking at just random fluctuations, and we should always keep that in mind as we look for root causes. I'm not,
Oh, yeah.
I mean, I'm not saying we shouldn't look.
I think we wanna move the whole median down.
But
Yeah, the goal is 0.
Yeah.
yeah, right, but when you make a change, it also takes you 8 periods of observation to see if the change made a difference. So otherwise it's flawed, it's interpreted.
Thank you very much. I think we're at a shifting point, and it's perfect because it's time now for public comment. Anyone in the audience is not in public comment, I wanna remind you that we listen, but we don't answer questions or dialogue with you. And if you would like to speak, please feel free to state your name, your address, and, 3 minutes, so keep your remarks 3 minutes. Are there any public comments? None? All right, thank you. Hearing none, we'll move on to our next, agenda item, which is emerging healthcare topic. And today we're very lucky to have Carol Mosier, who's the executive director of the Benton Franklin County, Health Alliance, and which is the agency for the Greater Columbia Accountable Communities of Health. And she's going to give a presentation on ACOs, accountable communities of health, which is a current movement in
That would be great. Why don't I just sit here, take Mandy's lead? Well, thank you for having me here. Really, I owe this position with Greater Columbia to Julie Peterson, because back in 2014, about June, the Benton Franklin Community Health Alliance pursued a planning grant to become an accountable community's health. And Julie was very encouraging that the Benton Franklin Community Health Alliance, which had been in existence since 1992 and was a bi-county health collaborative, go after this grant. And we got the grant, and the rest is history, and now we're all joined in our regional service areas. So thank you for this opportunity to talk about what's happening in terms of healthcare transformation in the state of Washington. And I would be remiss if I didn't acknowledge a couple of my members of my leadership council, Robin Reed and Liz Whitaker, who drive all the way from Ellensburg to attend our monthly meeting. So thank you guys for coming.
I'm the one who's gone most recently. Robin started, but I've been going recently. Yeah.
Thank you very much.
From our public health department. And then on our board of directors is John St. Clair, who's your fire chief. So he's actually the secretary of our organization. So he's on the executive board. So this is a map of the Greater Columbia Accountable Community of Health. It's one of the largest geographic regions in terms of ACHs across the state. It comprises 10 counties all the way from Kittitas to Asotin, and it also includes the Yakima Nation. And if you have any questions, just go ahead and interrupt me. So each one of these ACHs have been in existence from about December of 2014, July or January of 2015, and they've all developed either governing boards or councils or some kind of a governing entity, which is required as it comes to the Medicaid waiver, which I'll be talking about in a few minutes. We're also responsible for looking at our region and designing a regional health improvement plan based on the priority needs of the communities, and we have had several retreats to get together as a 9-county region to take a look at our community health needs assessments to determine what those common needs are, and then develop a plan to address them. So the mission of GCACH is to advance the health of our population by decreasing health disparities, improving efficiency of the healthcare delivery, and empowering individuals and communities through collaboration, innovation, and community engagement. And then we think we have a pretty cool logo too. Guiding all this work, actually we came up with our guiding principles as we were embarked on the Regional Health Improvement Plan, realizing that there were some fundamental principles that really needed to guide all of our decision making. So we came up with about 5 guiding principles to promote a culture of health and health equity, to facilitate a regional health approach, population health approach, to engage the community, to focus on prevention and early intervention, and then ensure that all of our strategies are data informed, aligned, culturally competent, and sustainable. This is just an organizational chart showing you who's on the board of directors. Essential to these accountable communities of health are the
idea of collective impact, and that when you are trying to make transformational change, which is very difficult, the only way you can really accomplish this through all of these different complex systems is having those systems at the table. So you'll see that we have all of these different sectors that come together to talk about health and healthcare transformation, and each one of these sectors has a nexus into health. As required by the Medicaid waiver, at least 50% of our governing board has to be outside of the actual health care delivery system that's traditionally known as the clinics or the hospitals or the physicians, and to really branch into those social determinants of health, because as we know, so much of our health is determined by our social determinants, poverty, education, access to transportation, those kinds of things. So we have a lot of different agencies that come to the table every month to talk about, what do we have in common, how can we collaborate together to put together interventions that really have a meaningful impact. We have a very busy organization. You can see how we collect from the public down to community members, and then they filter into all these different partners and sectors. So we've got all the different sectors represented. We have the Leadership Council and the Governing Board, and within the Leadership Council, we have established 5 priority work groups, and these are based on the 5 identified priority areas of our service area. So we've got care coordination, behavioral health, healthy youth and equitable communities, diabetes and obesity, and oral health. So those are the 5 kind of subject matter expert work groups. And then in addition to that, we have several committees that just help us operationally. So we have an assessment and planning committee that meets prior to our meetings to make sure that our agendas are robust and to the point, and that we can get as much done as we possibly can, because we have people coming all the way from Ellensburg to attend our meetings, so we want them to be meaningful. We have a data committee that's taking a look at all the data that's needed to analyze what our intervention should be, and then the strategic issues committee that Liz was on was part of the group that came up with our regional health improvement plan. And then within the board of directors, they have several committees as well. So in terms of this organizational structure for the Medicaid waiver, each ACH needs to be a legal contracting entity. So GCACH is in the process. We have formed a nonprofit corporation. We have an EIN. We're proceeding along to get a 1023, so that is recognized by the IRS as a charitable organization, so that we can obtain grants, and that will be expected when it comes time to get the Medicaid waiver to be able to do contracting with various agencies. And then I hit those other 2 points earlier. I talked a little bit about our shared regional health priorities. And then as we were going through this process, we discovered several gaps that were common to all of our areas. So we realized that common to us is that we needed more behavioral health training. We lacked community-based behavioral health services and psychiatric services. We needed care coordination for special populations, especially I think in care transitions, which is actually one of our SIM project, our state innovation model project. We lack access to healthy foods. We need more diabetes and obesity self-management programs, healthy community design, physical activity programs, diet and exercise programs, and then in terms of the other area, we could use more adult and learning programs, higher employment and housing programs, higher education access, trauma and parenting training. And these gaps were discovered through careful analysis of all of the programs in our 10-county service area. We did a huge regional assessment of all of the inventory of programs and services, and realized that when it came to our needs, we were lacking in some of these areas. There were 4 areas for all 10 counties ranked lower than the state average according to the county health rankings. One of those was access to exercise opportunities. And we know how important exercise is to controlling diabetes and obesity. And you can see where all of our counties kind of fall short from Washington State. And really access means, can you get to an exercise facility, a track, a swimming pool, a trail. So you can have the best trail system in the world, but if you can't get access to it, then it's probably not going to serve the needs of your population. We also in our area have quite a dental shortage. We're a dental provider shortage area, especially Klickitat. When we look at our median household population of our 10-county area, we have approximately 35% of our total population in our 10-county service area that receives Medicaid benefits. And this is primarily due to the agricultural nature of our region. We have a lot of farming and a lot of produce and a lot of value-added production, but they're not the highest paying wages in the world, and so as a region, we really do have a lower median income. Approximately 260,000 people receiving Medicaid benefits out of a population of 725,000. And then I think everybody in Washington State is suffering from a lack of mental health providers, and so this is very common across the United States, but I think Washington has been, unfortunately, one of those lower ranking states in terms of provision of medical health services. I'm going to switch a little bit now to the Medicaid waiver. I don't know if you're aware that at the beginning of the month, the Healthcare Authority received word that they have received some funding from the CMS, approximately $1.5 billion, that's with the B, to address some of these healthcare issues across the state. The ACHs are meant to be the accountable community of health organizations, are kind of the linchpin and the coordinator to determine where that money should go to, what kind of programs should be funded to address these community health needs. And so there are 4 major goals of the Medicaid waiver, and this is primarily for the Medicaid population. One is to reduce avoidable use of intensive services such as emergency department and hospital readmissions, to improve population health, to accelerate the transition to value-based payment rather than fee-for-service. So that's a big change in our medical system. And then to ensure that Washington's Medicaid per capita cost is below national trends. Initiative 1 of the waiver is delivery transformation, which is what the ACH is involved in, but there are actually 2 other initiatives coming out of that waiver, one for long-term services and supports, and housing and workforce development. The vast majority of these funds will go to providers, and so the ACHs are meant to coordinate that provision of transformation services. And the way that the ACHs will benefit and the providers will benefit is when they determine what those projects are and they reach certain benchmarks, and they will get an incentive payment from CMS. So this is not a grant program. And we're not at risk. Everyone's very concerned about the ACHs being at risk. We're not at risk unless we do not meet the milestones that we've identified in our work plans. We've heard that now our Medicaid toolkit, the projects that will be listed on our toolkit are very similar to the toolkit that you'll find in the New York waiver. New York State has been in an 1115 waiver situation for about 3 years. And so when we look at their toolkit, we can kind of guess to see what kind of projects that the state of Washington will be going after. But I'm really pleased to announce that it looks like almost all of the projects in the toolkit, at least in New York, are very similar to the kinds of projects that we've identified for our 10-county service region. So we're primarily identifying Initiative 1, the delivery system reform. So what that means is just the projects that we pick really are meant to transform the way that we deliver Medicaid. Right now, the state of Washington is kind of the leader in terms of making this transformation, and their goal in terms of their delivery system, which they have all the Medicaid clients, and then the public health or the public employee benefit group, is that 90% of the health care purchased for Medicaid and public employees will be value-based by the year 2021, 90%.
And correct me if I'm wrong, but there's no discussion about rural being exempt for that. It's statewide, so.
It's gonna be a challenge. So the way that the Medicaid waiver toolkit is going to work is that the Healthcare Authority and CMS are negotiating right now what's going to be in our project toolkit. I think in a few weeks we'll have a glimpse of what that toolkit looks like, at least that's the rumor that I hear. They will develop a scoring guide, a template where we can list our projects and go after certain projects. And then they have specified areas that we will apply for. So whether it's a system capacity building, we need more healthcare providers, telehealth, whether it's a care delivery redesign in terms of care transitions or care coordination, and then just generally prevention and health promotion. Everyone's very worried about, well, are the health, is that ACH going to be the organization making all these transactions, and I'm really happy that the state has landed on hiring administrators for the funds so that all of the contracts will go through review and the funding will come through an executor at the state level. And then an independent assessor will take a look at our projects to make sure that they meet muster. So this is kind of the process flow. I might have noticed at the beginning of the presentation, I borrowed this from Eddie Miles, who is the hospital representative right now to the Greater Columbia ACH. So he kind of came up with this graphic to explain how this would happen with entity has an idea, the ACH, and we have these 5 project work teams that will take a look at these projects and make sure that they align with the needs of our community. We'll work with the entity to make sure that it aligns, and then we'll submit that project to the state. If you're interested at all in following all this activity, the Healthcare Authority has a wonderful newsletter you can get on their listserv and read all about what's happening almost on a weekly level, because it's constantly changing, to see what the most recent information is about accountable communities of health and Healthier Washington. This is just an example of what the toolkit might look like. So, for example, if we're looking at a care delivery redesign project, we're looking at bidirectional integration of care. You've got objectives and core components, and then one of the most important things about the Healthier Washington initiative is that everything has to meet muster in terms of data. So I don't know if you know, but the state has been very actively engaged in producing what they call a data dashboard, and all of the ACHs will be measured, as will the managed care organizations, against the performance measurements that have been produced. There's approximately 55 at the state level. They're primarily clinical data or clinical measures, and we'd really like for them to start including some more social determinant measures, population health measures. But for now, all of our projects will be guided and measured against these clinical measures of the state. Some of the implications of this work is, how does that project support the vision of the ACH for a transformed system? How do we select those projects? And so we'll be working towards a really robust plan to what those projects are. And then ultimately, probably our board of directors of the ACH will determine which projects will be selected. And that's it.
Thank you very much. I want to say that was a really rich and substantive presentation. I didn't get all the data on the slides, and I think I want it. Is there a way, and we have some slides from the presentation in our package, can we get the full presentation?
Absolutely, yeah.
I think it'd be very useful. useful, because the small print, there were a lot of things in there I wanna know more about, so.
If permission, do you guys wanna add anything about the work of the ACH and the direction we're heading, or?
You didn't put in anything about the regional health improvement plan at this point, and you didn't give any details about the
Sim project.
SIM project. I mean,
Because I took it kind of off cue from Eddie, but I was really interested in Mandy's presentation because as part of our regional health improvement plan in terms of coming up with all these different areas and what we're going to do, we also have to have a proof of concept for a project. So we chose as an ACH a care transition project, and it actually came out of our patient safety group, Julie, and looking at our own hospital readmission rates, especially in Benton and Franklin counties. And I think that the state has divided us into 16 different regions, and we used to be 15 out of 16 in terms of worst readmission rates, and now we're dead last. And so the project that we're doing is the transitions project, because the Medicaid penalties or the Medicare penalties for hospital readmissions are increasing, and so and then the patient outcomes are very, very concerning. And so we are actually using the Consistent Care Services group that Julie's very familiar with to manage the care transition program. Learning a lot, about what successful care transitions look like, doing our own research, coming up with a tool, it's called the 8Ps model that we've kind of modified somewhat because you really need to go into those social determinants and choose partners. So we have Meals on Wheels as one of our partners, aging and long-term care. We're really lucky that the WSU and RSN nursing students are helping us with this project. We've had some help with PNL and Daryl Coles, who is a risk scientist, to help us determine which process measures we're going to land on. We'll be using community health workers to go out to the homes to make sure that the patients have the things that they need in terms of medicine reconciliation, and if they have chronic disease, there's a critical pathways checklist that they'll be working towards. So actually really exciting. We're just getting that project off the ground. We've had about 4 project work team meetings, and really anxious to get that project underway.
I appreciate that. I was interested in hearing an example of what you see as a successful or promising project. How does the ACH relate to the particular stakeholders that are involved? I'm still trying to get a sense of the structure and the relationships between that and the different hospitals and the patients. How do you work with hospitals to do these things? Do you deal directly with patients? Do you deal with the community health organizations?
So are you talking about the actual projects themselves?
Yeah.
No, so we haven't actually, this is our first project, so we're working directly with Cadillac and Trios, and so we have their discharge planners involved and their case managers involved in the project. And then as we scale it up, then we will go out and hopefully work with all the other hospitals to find out, so what does KVH need in terms of, improving its readmissions if you're looking at that. And so that will be in the next kind of iteration when we get funding, because really right now there's not a lot of funding behind the ACH, and so this Medicaid waiver then will provide that kind of funding so that we can scale up these projects. And then hopefully work with a team within the community that can help deliver those services.
And the team within the community could be just about any group, the hospital, the public health department.
It could be varied depending on what the community is. So if there's already a community group that's working on a particular project, then we definitely want to work with that group, and if they want to scale that up and include other partners. So it's really depending on which community and what they have going on, if anything, or if they're rural or if they're urban. They might have much different needs, and so we're anticipating that the scale of the project could look quite different in Columbia County as opposed to the Tri-Cities.
So the CMS, they determine the categories of funding, or do you guys help work with CMS to get, what they're gonna, what projects are actually.
Right, so,
That would
the-
make us,
exactly, the healthcare authority will work with CMS on the actual projects, and then we will have to justify the funding to this independent assessor. And, that's where I think that we'll need some people that are experienced in, scaling up these projects in other regions. I know that there are consultants in New York that have done this work that might be very good for us to have somebody come out and be consulting with them so that we can get some idea of what it took to scale up a project, because it's gonna be pretty big lift.
I think it's time to move on. I wanna thank you very much and thank
Oh,
you
yeah,
for,
that.
Can I ask a quick question?
uh,
Are you partnering with any EMS agencies down in Tri-Cities
Oh,
for
yeah,
this?
yeah,
Because I hope so, because they're mobile and they're there. I work for the fire department here, so it's something we've been looking at for quite a while. It's a great partnership.
they're very great partners. Well, thank you very much.
Thank you.
thank you very much. And I appreciate the fact that someone will know the distance to be here. Okay. Chief Executive Officer.
I did include, Frank included on my behalf a written report. Did you have any questions on that?
Now you talk about Project Access. I appreciate it. So you think that it's proceeding smoothly?
And I know Randy's planning on spending a couple minutes in the program as well.
Okay, good. I'll wait till then.
In addition to that, I just wanted to mention that today, we had our second, Lunch Plus One. And so for 2 months in a row now, we've had like 65 people in this room, and we just did light topics. And it really got very busy today, and people were having great conversation about multitasking. And, as someone mentioned, there really is no such thing as multitasking, and we all actually did a little test, of the impact that trying to do two things at once does on your accuracy, your stress, and really your efficiency. So, we spent some time with 65 great people in here and made sandwiches today after that. I also just wanted to mention, I think I have now been to every Rotary Club in the county, correct? All right, so I was at lunchtime Rotary this week, and also had a great opportunity to meet with Women in Business Club at CWU this week. Thank you for participating in the meeting with Representative Reichert. I think it went really, really well. I don't know if you have any comments on it, but they got back to us and appreciated the content, and then also appreciated the very direct ask that we had. This is what we want you to look out for. So heard back from them, and then Community Health of Central Washington also had a piece of that presentation, and they appreciated being included. So I think there is a really unique story to tell about the two hospital districts, the impact that Interstate 90 has on us, and then how we partner with so many different groups in our community. So don't be surprised if you get a call from Reichert's office asking for testimony or asking for something.
School district, do you have a presence?
They did, we had commissioners, and then Jeff Shear, the operations manager from District 2, showed us his Google map of where all the infamous along I-90 were. And Commissioner Hartley, I can't pronounce his last name, pointed out, I was calling out 10 million individuals who travel through the districts on I-90, and it's actually closer to 30 million here because there's 2.5 or so people in each one of those columns. So to think about the responsibility of having 30 million people in your care for 81 miles was pretty impactful, I think, the representatives. So, but again, thank you for that, and I did not prepare a District 2 report since you guys were with District 2 commissioners just this week. We are going to be meeting with our directors and leadership on Monday about the budget. So we're going to go through the capital budget. We're well along the way with the operating budget, but I think this is our take the gloves off meeting on Monday. So we're going to lock the doors to the conference rooms, and some of us will emerge. I just wanted to mention, and Carrie can do this or I can do this, but our evaluation delinquency rate in May of 2016 was 73%. And at the end of September, it was 2.3%. So we've made great progress on that.
Yeah, very good.
been a while since.
That is good news, and I know we've kept them hopping down there.
Yes, we have, yep.
And I also wanted to mention, we have our insurance advisory committee up and running. We're looking at benefit rates for 2017 right now. But we have been very, very successful in enhancing benefits with the virtual care ladder. So we're going to roll out a pilot to enhance benefits to all of, not just our employees, but everyone who has their dependents on the plan will be able to access virtual care. We've created a portal specific to our employees and enrollees, and they'll be able to get on and use that service free of charge. So we're really looking forward to that. And also, Human Resources is launching a wellness program. So it's going to be Fit to Care 2.0, since Fit to Care was what we called the program before. But so we're looking at ways we can challenge each other and get people really involved in wellness. So seems to be very well received by the Insurance Advisory Committee. Any other comments on that?
I think that they're just very excited to be able to have some fun activities to participate and have challenges with each other on. Everybody loves their Fitbits, and they love to have those challenges to get steps in and have contests and do it. So they're excited.
And I like to say it's not a contest, but if it was, I'd be winning. We've had 3 negotiating sessions with WSNA, and they're going very, very well. I think we agreed at the end of the last one that we're down to the stuff we're going to spend some time on. So we cleared away some language issues, have really created some great ground rules for interest-based discussions, have great people on the team from our side, people who actually work with the schedules and work with the nurses every day, so they're having some real candid conversations, and I think we're making some good progress. I just wanted to call out that I asked Frankie to include in your package the 5 questions that pertain to KDH and the Foundation's survey. And I asked to have those included because I really think it calls out that we can spend more time with the Foundation Board, making them comfortable advocating for us in the community. That's a large board, and one of the reasons that you have a large Foundation Board is so that they can be out in the community talking to all the people that they know, and it seems to indicate here that we haven't spent enough time educating them and really keeping them involved with what we do. So that's why those 5 are there. I hope we put together a work plan to work with the Foundation.
These, the recipients of the survey and the respondents are members of the Foundation Board.
Correct.
How do you anticipate that education happening? Is there a role of liaison itself? Is there a role that play with that, or is it curriculum materials to be changed, or you know?
So we just, and you should have received it as well today, Survey Monkey looking for a date for the 2017 goal setting for the Foundation. And my answer would be yes. I think as a representative to that board, it would be great if you could get up and talk about the goals and strategic objectives of KDH and really let that board have a back and forth so that they can go and speak about the objectives of the hospital. Yeah, I sort of plugged you into that.
Okay, great.
Are there any questions?
Do you have any comments on the HR dashboard?
My favorite part of the HR dashboard is the reduction in the delinquent evaluations. Did you have anything else?
To speak to that, Amy stole mine. Not right now.
Our turnover rates is simply improved over the last couple of years, so that's something we've been watching, and both Carrie and I and Libby and I are working on updating the dashboards and looking that we'd like to report going forward.
Okay, we move to the chief of staff report. You have a question? Oh, I just said thank you. Chief of staff report. That's what we're running.
Yes, you have the list of the providers that have applied for the privileges. There, the list includes Furhan Gourmet, who is an ED physician that occasionally works here. Christopher Hurd is a direct radiology provider with a remote radiology service. Ginger Longo is an OBGYN that has had privileges here before. She's applying for new privileges. Steve Eckhoff is an ED locums tenens with PA. Those are applying for initial appointments. William Waltner is applying to add an additional privilege, a higher level privilege of chronic maintenance of chronic pleural effusions due to malignancy. He's got a course in sustaining capacity and how to manage these special device that's made for this situation. Jude Repture is a PA that works with orthopedics, sometimes ED, sometimes orthopedic. Lori Drews is a behavior medicine specialist at Family Health here at South Ellenburg. Rhonda Ram is a ED nurse practitioner. And Wendy Brown is a Virginia Mason telescope provider. We recommended that you approve these applications as and privileges as they've applied for.
There's been a request from the board member to hold things until executive session about a couple of questions on the, can you stand for that? We'll do that. We'll discuss it in executive session and hopefully then come back in the regular session and formally approve the list of financials. So, please.
Okay, on page 24, we have a summary of September's operations. September, we continued with our lower than budgeted inpatient volume, but outpatient volume was very strong, which helped us in terms of revenue. We also, as you probably noted in some previous months, we had some accounts receivable days that were a little higher than we would have liked, and so there's been a lot of work spent. This is primarily the clinics, a lot of work spent in the month of September to bring those down, which has again had a very positive impact on our operations, because when we bring those AR days in line, then we're able to reduce the reserve we have on those accounts. Because on the balance sheet, the AR balance is there, we have to reflect how much of that we think is actually collectible, and the older the accounts get, the more we have to assume they are not collectible. So a lot of work done in the clinic to bring those down, which was a very positive thing for us. So I'm happy to answer any questions, and I'd also like to talk about interim cost report we filed and any questions? Okay, so as you know, we are as a critical access hospital, we are reimbursed based on cost by Medicare. And I think we've talked about this before because we did have a settlement or a tentative settlement of our 2015 cost report in August, and I seem to have told you that we were getting additional funds because our costs had not gone down, but our volume was down, so we get paid a little bit more per case. Well, we filed a interim cost report for the year 2016, which is something that most critical access hospitals do. In fact, I think if you don't file it, we're required to fill out a form with CMS, and they kind of file a similar to an interim cost report. So we filed that report, and we had Dinka Star Associates, our auditors, do that report for us. And it has been filed with Medicare. We've not heard from Medicare directly yet to see if they accept that, but based on that cost report, we would have another rate adjustments upwards because again, our cost hasn't gone down, but our volume has stayed down. And based on that report, we could receive a lump sum adjustment for 2016 operations of roughly $590,000. And that would true up our claims through June 8th of 2016, but there also would be proposing a change in our interim rate to go up roughly about $200 from $4,445 to $4,638 per Medicare day.
So this is a pretty significant, impact for us. We've not recorded that in the financials yet because we want to know from Medicare that it has been accepted and that they would agree with that. So do you have any questions on that? Can I
Where will that show up?
Where will that show up?
Yeah.
In the financial statement?
Yeah.
It will show up as a reduction to contractual allowances. Because if you think about it, that's truly what it is. It means that they paid us too little for the claims based on our costs. So it will reduce the amount that we've shown as contractual allowance. And it will show up in our operating income. In the month that we hear that we're going to receive it. And we've had some discussion about how to reflect that. I'm probably more comfortable with reflecting it in total in the month that we hear we're going to get it, and then we would call it out for you as an kind of out of ordinary monthly, and not a typical monthly transaction.
2016 comes about twice what it was in 2015.
Right.
I said 2016 is about twice what it was in 2015.
Not everybody has that schedule.
Oh.
What Bob is referring to is the tentative settlement that I discussed with you that we received in August. That was based on 2015, applying what was in the 2015 filed cost report with what had actually occurred in 2015. So the point of that was to true us up, to change our rate at that point in time to what it should have been, our payment rate based on 2015 costs. So that was all 2015 related. What this is actually what they need to pay us to bring our 2016 payments up to what 2016 costs are. So, does that make sense?
You recognize that in office?
319, I believe we recognize it on.
Right.
I would mention also that there are obvious implications for Medicaid as well. Medicaid, however, is well between Medicare and
So this is, that's why I'll have to make an editorial comment. This is why it's a good thing to be for Access Hospital. Because, we've seen, our volumes reduced on the inpatient side, and it's virtually impossible to have our costs go down by that same percentage because we're a high fixed cost organization. We have the staff that would be in inpatient units, other people are not. So that's what that's why we have the critical access hospital program. Any questions?
Okay, resolution 16, Passion Car, I can't find that in the packet, pages that are on.
And while we look for that, I'd actually like to introduce Kelly, who is here tonight. This is Kelly Lillian Elise. Who's here. And Kelly is our new director of finance, and she's been with us since the beginning of the year. Was it December?
August.
Oh my God. Anyway, Kelly's been with us. I just did her 90-day evaluation today, so sadly I couldn't figure that out. Anyway, Kelly came to us from Moses Lake, and we're really excited that she's here. Great experience as a controller down in Moses Lake, and just the right combination of skills that we were looking for to step into our director of financial. So we have a resolution tonight to appoint her as the district auditor.
Moved and seconded, any comments or questions? All in favor? Aye. Opposed? That motion passes, congratulations, Kelly. Finance committee met, my papers are all over the place, I apologize. We met on Tuesday morning and we went over the financial highlights for the month. Talked a little bit about the plans for the statutory requirements for approving the budget for the next year. And Medicare and cost report, and then we had the submission of a capital purchase item, which is one page. Here it is, it's in the supplemental, I guess, I'm sorry.
26A.
26A, and this is, Randy, I think this was in this here, for the purchase of the installation of a pad on which the mobile CT unit will sit until that unit is replaced by a permanent new one in the hospital. Then that pad will remain so that in the future, when we have other equipment that we lease or that we add that's new, we'll have a place to put it with electrical and power accessible to it. Is that a fair description of what we're doing? So it was budgeted for, the cost of $54,800 includes a contingency of $5,000, and it is to be funded from reserves. Are there any questions or?
Where's the location?
It's just to the north of where the current MRI building is, just to the north there in the parking lot. And it's not so much a pad as it is a site with all the electrical and data.
Pad is available.
There will be a concrete pad there.
I did not realize that we didn't have a mobile location, because that anytime you're going to swap out a CT or MR, that can have real consequences if we need to enter the facility and whether your emergency department's on alert and things like that. So I think it's really important, and it's a nice enhancement that we'll be able to make those kind of moves.
And Ms. Rainey's credit, he pointed out that we did have a pad, but we had a cooling on it right now.
There used to be a pad, we used to go in it all the time.
We actually had a secondary one, which was on the very south end of med surg. That can transport patients all the way down to med surg and the patient care. So,
So this one seems to make a whole lot of sense. Are there any other questions or comments? Do I hear a motion to approve? Too fast. Moved and seconded, all in favor? Aye. Opposed? Motion passes.
Mention one thing about maybe if there were up to date on the EHR selection.
Oh, that would be good because there was a big meeting on that.
So, I just wanted to let you know that we had a meeting of our selection team last Friday, and they have narrowed, narrowed the choices down to one vendor. We're in the process of, we'll be doing site visits with that vendor, and then starting to negotiate a contract. I will tell you who it is, but it's not a final decision, and we don't want them to think it's a final decision in case we want to make sure that they meet our needs, but it's CERTA. And they're actually, we're ahead of the pack considerably. So we're planning on, trying to get a site visit completed, in the month of November, because we'd like to be negotiating the contract and moving forward as soon as possible. Julie has challenged us to go live by, June 30th, which is gonna be a big stretch for us, and it remains to be seen, but we're gonna try.
It's really good news.
We're excited. Although it's surprising, every time we get together, there would be one vendor that I would be sure would be totally out of it, and it wouldn't be. So it was interesting, but Cerner definitely is the most favored system at this point.
I don't think that it was.
Okay, don't say. What?
June 30th.
June 30th is our challenge now.
When are we hoping to have the deal?
Finally.
Inked and dry?
I would think we have to have that in December. We have, I should say that we've got site visits that we want to accomplish by December 1st, but we also have, Cerner coming on site next week for a couple of meetings, with all department directors, to kind of talk about the process of implementing. Also, a meeting with, IT, our IT department, to sort of talk about some of the technical stuff. I think that's scheduled for Wednesday, and then one meeting with Julie IT. But
This is long awaited and very welcome. Okay, next item on the agenda is education. I believe one commissioner or two attended the WISHA annual meeting. I'm sorry. I didn't mean to slap you.
No.
Back.
Thank you, Bob. Do you have my written report as well as my dashboard? Are there any questions? Matt asked about an update on the project access.
Yes.
I have completed all of the overall, kind of consolidation of all three presentations that you all got and gave that to all of the clinics and all of the leadership in the clinics with the providers, and that went really well. We had lots of good dialogue and feedback on process improvement, and had resulted out of that first initial meeting with the whole group. We had one provider open up this panel, which was to new patients, which is exciting. And then they started the one-on-one data with each provider. Started with FME, Family Medicine Ellensburg, and then about halfway done. And through that, I've had one additional person open up their panel so far without even having to do anything, just volunteer to do that, which makes sense after they saw their data. And we've had really good feedback on different ways of scheduling for them and how they could improve their practice while we wait these different changes in EMR and staff. So
In general, this is being fairly well received.
yes, actually, it's been very, very good for both of us. Always.
Yeah, it's, you said the doctors, the providers, I should say, are quite happy about this, because they would rather spend more time with patients and less at their laptop.
So how much, how much of that kind of creative thinking are you having to do in order to free them up from that kind of work?
Actually, so far, they've volunteered the creative thinking in their schedules. They came up with good, positive solutions to being able to add patients or increase here, decrease somewhere else, which was really nice to see them thinking about it. And when they're presented with the data that, realistically, this is how many visits you could need to increase to be at the median, they recognize that and want to be creative in getting there. So,
I want to get really just briefly into the nuts and bolts of it, so without naming any names, could you give me an example of what sort of change is happening in order to make that possible?
One provider got creative. He was working 5 days a week and decided to go to more of a 4-10 solution, which actually increased his capacity about by 10. It was even double what we asked. Of course, the proof is in the pudding, so we'll see. And then the other one wanted to decrease her FTE actually, and decided that if she could meet her personal goals as well as our goal by going to 4-10s as well and increasing her day and being more creative with her scheduling. And that was a great win-win solution.
Thank you.
How is what should I call them, provider reporters?
So the strategy.
I was gonna ask the same question.
How, is that just maintaining so far, or is it on hold, or is it progressing?
We're progressing. We actually just approved our first Scribe job FTE today. So we met yesterday to kind of finalize the whole job description, wage scale, what we're really looking for the person as well as education. And decided that we want to kind of start small and work out all the kinks in the training part to make sure that we have it.
That's what's ready to start.
So we're just gonna hire one at this point and work with our current pilot, one of the doctors that we piloted with our own.
Dr. Larson.
Yes, and have him really help us develop that role before we hire a whole bunch of people.
What will we ultimately call it, or is that still for the second?
Oh, I gave up.
Yeah.
Yeah.
I would take one for the team.
Strides, and so everybody was whispering the words. But yeah, so, but they're gonna be scribes, so.
Personally, I miss the touchdown to the TV, we liked that one. Scribe. Yeah, it was, transcription documentation or something.
I suggest calling them docs for documenters, but
The doc.
I need a doc. Well, thank you for that update, I appreciate it.
So you're gonna train this person then next year, and you turn around and train them.
Well, and that's also kind of why we're taking this slow, especially with our, fast approaching EMR. We wanna kind of get this right and then launch.
We're really pushing the EHR timeline, it's about making it more efficient as well, that's the number of things that next gen is not. So we owe it to them, I think we're gonna open the file
So, year to date, the clinics are about 11% below budgeted visits, and so is this going to impact them? How much is?
I hope so. We are seeing an uptick in our visits, but we are coming into our busy season, so is it seasonal or is it really sustainable? I'm not sure yet.
We gotta have now the more providers out.
That was true.
We have really see. We got an app, more now, knowledge in 1 month, where numerous providers were out, far more, which gave rise to having a conversation with the providers about, we can't all do it at the same time.
Yeah, I felt that abnormality had happened many more times than recently, but clearly we have a very good recipe for fixing it, and I'm very.
It's such a frequent abnormality, it became a normal. So you think that this, by the end of the year, this will, at least we hope, come up?
I think just even looking at seasonally, it should come up. So I wanna make sure going into next year that it's not an artifact.
Right.
The other thing I would point out is, we're looking, we have a project on, employed provider incentives. And we're working some of these project access goals into those incentives as well, not just with productivity numbers, but if, did the clinic achieve their goal, did the individual achieve their goals?
Very encouraged that the solution appears to be ground-based. Doctors coming out with some good solutions to work together, so the chances, that's tremendous.
So then in the, on the clinic operations dashboard, when you look at the third available appointments and the different, are those the targets, is that the targets that we set, or is that national norms?
Usually it's natural norms for benchmark and so yes.
Is that into?
Yes.
Anything further on clinics? Thank you. Okay, now Bob, you can report on attending the WISHA annual meeting in October.
I thought of, being my first meeting, it gets just all kinds of kudos. Seems like I'm others to compare it to, but the governance, the day before, I found very helpful, and there were a lot of people there who didn't have to go out. So, that was very helpful. We did some concessions, Patrick Kennedy, Patrick Kennedy was the keynote speaker. So that was interesting, and we talked about his efforts with drugs and his personal issues with drugs. So it was an on-point conversation.
If Patrick Kennedy is the son of Edward Kennedy?
Yeah.
And was he the one who lost a leg as a young man on his skiing accident, and then
I'm not sure if he was that.
it was, because I think that's what started this program.
He was Kennedy that in the middle of the night, ran into some barricades outside the Capitol, and he was, to say the least, not himself. And we talked about that. It's a very candid conversation about addiction and violence. And I thought it was
Okay, moving on to old business, the first item is the board meeting evaluation survey, and the results are in your packets. And I really like the fact that a lot of people need, I am the one who didn't read her report, I apologize.
Sorry.
Yeah, Frankie, if you wouldn't mind having a paper version of that in our packets as well as inviting us to do online, I'm much more likely to sit down and do the paper version than to do it online, so. So that's for the future, you don't have to bother. I actually have one. Oh, that's wonderful, so you can pass it on our website. But I think that the new format generated a lot of really valuable feedback and much more specific and more direct and particular than what we had seen before we did it. So we were doing this as a mock-up, and I asked if everybody's satisfied to keep doing it for a while, and
Sure. Yep.
okay, done. 2017 board committees, all right. There's a handout, there's a pages 32 and 33 in our packets. The standing board committees are on the top, and then the special committees are on the bottom of the handout. And the third column over lists the 2016 members, and the fourth column lists the probable 2017 members, and the alternates. So what I want to say, I have a couple of corrections, but then I want to note that since Bob Crow joined the board after we did this template, we wanted to talk with him about his preferences. Would the board prefer that we, actually, I don't know. So we'll talk about it right now. The QI Council has Matt and myself and Erica as an alternate, and I have to be on the committee because it's part of our bylaws, and then the Finance Committee, I'm currently serving as chair, and Bob Crow is the other member of that committee. Bob Davis is not on that committee at present. He has moved over to the Medical Executive Committee, which is in the second bottom section, because that meets on the one day of the week when I can't be there. My pleas to have that changed were met with no response by the members of the committee. So if I am able to attend, since in theory I'm the statutory representative, I will attend. But if I do show up, it still means there are only 2 board members present, so it doesn't make the public meeting. But if I don't, Bob Davis representative. Is there someone who would like, I suppose I could put myself down as alternate. Is there anybody else that would like to do that? Medical executive committee, that meets once a month, and it's the one that reviews the credentials that are being proposed for board approval and other medical issues that are of interest in the provider community.
Could I correct that? It's at 12:30 p.m., not 12:15.
Would you like to be the alternate then, Bob? Are you willing to be, and then I can attend sporadically? Strategic Planning Committee, Julie, do you want to urge us to?
Yes, and actually, I had a phone interview with VIA Consulting, who are the folks that did the governance education blog referred to at workshop. What I had, they have a proposal for us both for governance education and development for 2017, and a separate proposal for strategic planning. And what I was hoping is that I could get a couple board volunteers, 2 volunteers to help me do that interview and see if that feels like a good fit. I think the alternatives are some familiar faces like Jody Corona from Health Facilities, or AWPHD or some WISHA resources. I'd like to look at something new maybe to help develop a really robust sort of governance development structure and education plan for the governing board and then the strategic.
I'm open to being involved in this planning process.
So Frankie will get a hold of us and we'll put together a time to meet. So, thank you.
I do want to underscore that I really like the idea of maybe a new organization shepherding the process. I think it's healthy, we don't be sort of stuck in the same old boxes. It's really
these people have been very highly recommended, and I've seen their fees and they know that. But it will be an investment.
Yeah, it's an investment, absolutely. Joint Districts Committee, positive districts on the 2016 Erica and Don Davis served on the committee. And how often we met, would you be willing to continue, or there's someone else I'd like to? Okay,
If that opportunity is available.
I think it is available, let me just pick this side up. Master Site and Facilities, Bob Davis is our established member. I know that there has been some sentiment to have another board member on that committee. I cannot do it, I think it's just more than I can manage. Bob, who are you volunteering to be? Bravo.
Them on the site work and things.
And then I'm thinking that apparently you'd like to continue on foundation. Sure. Compliance Committee, have been Pam Wilson. Do we need a member, a board member on that committee?
Pam had actually expressed interest in doing it because of her role at the bank. She was involved in compliance. Certainly welcome, but it was new, I think, within the last year or so.
Is anybody particularly interested in compliance issues? Would like to do that? Let's say if we need a board member in the future, you'll come back to us. Okay. Community Healthcare Roundtable, Matt, I hope you'll continue because you've done a great job with that.
Sure. I would like to.
All right, thank you,
Because I
Bob.
remember being a participant, I thought it was one of our very high value initiatives.
Excellent. Rural Advocacy Day, let's not think about that until we get closer to next September. It is an extremely valuable and useful experience. It's very educational and it enables you to make contact people, connect with them.
This is in Washington.
Yeah, Washington DC.
So it's September every year.
Well, can I just mention that what's in September every year is the Washington State Rural Advocacy Day, and they're partnering now with Oregon. But the American Hospital Association also has an advocacy program that I believe is in baseball. So there are a couple different opportunities for that to and then the AHA annual meeting.
We may want to get some information about both of those things, Maggie, when you can get them for us. Oh, no, you're gonna look at it. Yes, I will do that.
Yeah, the sooner we can get specific cases.
Liaison with elected officials, I think that that's more ad hoc positions. Okay, so you got notes on all of the new assignments and so forth, excellent.
And talking about elected officials, I thought that was very successful. That's very good. It was very close on the point. Everybody had their notes.
Very collaborative also.
Yes.
And all the three of us, and then 3 members of the county district. And some members of the team.
Community health.
Yeah, that's true.
But it really gave the impression of a very cohesive from a county-wide perspective group of people. And I think that really helps with elected officials. That we thought about.
I might supplement by saying that I happened to go to a gathering where Dave Riker was the featured speaker. This was a couple of weeks ago, and I cornered him and talked to him and prepared him for what he was going to be doing in a couple of weeks. And so he was, I think his antennae were triggered a little bit. So I feel that just having that initial opening and then the follow-up really got us on his radar.
Well, and it's important, what we hear is the official senior member on Ways and Means, which was all CMS affected, goes through the Ways and Means committee, so, and I got a signed copy of this book.
And I have to tell you that I read that a couple of years ago when I got my son. And it's actually a very good book. It's intriguing. It's well written from a former sheriff to write a book as literate as that. It's very good.
They get a lot of practice, right?
They do, true enough. But it has a certain panache to it, right? It's a distinction that you might not expect. I really enjoyed it. Okay, new business and December regular board meeting, but also I want to mention that the November regular board meeting will be on December 1st. Right after Thanksgiving, not quite a rush it in a couple of weeks before. So that is Thursday, December 1st.
I have a previous.
And I know you do.
Out of town commitment.
No worries. And then, on December 29th, our December board meeting, so after Christmas, December 29th on Thursday. Now, I hope that, I know that a lot of people are gone between Christmas and New Year's. I think we need to meet in December before the new year, in case we have any budget issues, everything that has to be resolved and settled before the end of the calendar year. But we can, if we need to, call in and attend the meeting. I tell you. And November 8th, thank you, November 8th is the preliminary budget approval meeting. That's election day, so after you vote, what time is that? It's 5:30.
And that's the public hearing.
So you
It will not be a long meeting.
5:30, correct, tax, yeah.
I agree in the December meeting, in the holidays, each time we have something scheduled, and we should have not, we didn't.
And I think, a couple of members have pointed out that we wanna try to stay as close to the schedule as possible, so it's predictable for the members of the community. But sometimes we have to make changes. So the 2017 board calendar is in your packets, and that is page 34. And thank you, here's the AHA annual meeting is on to that's May 7th to 10th, and I'm really interested in possibly attending that, so.
Now, these dates are as good as I could get, and I'll try to look again, and as soon as, I'll change them, you know, to the calendar, but, I think they're accurate.
WHR is Washington World Health Association. And we have often had a member of the board attend that, but not for the last year. And then.
Robert this year. This is not the one that.
Oh, that was the one in Spokane? Yeah. I apologize, we absolutely did attend that. And then the conference in Chelan in June, and the Wish annual meeting here now. Are there any comments or questions about the plan, schedule? We can always update, modify as necessary. Done. There are a few articles and communications in the packet and in the supplemental. And I encourage everyone to complete the board meeting evaluation summary, and as much as I was negligent, I will get that done tonight. At this point, unless there's no further business, we'll recess to executive session to discuss real estate and personnel under RCW 42.30.110 parentheses B parentheses G.
That means we don't go.
When we come back.
I'm getting ready to
Thank you
tear
very
up.
much. A time, let's set a time of 7:15 for our executive session. Thank you very much.